In terms of when these patients see a specialist, a pulmonologist, what's the typical evaluation that takes place? So the patient has been screened for their shortness of breath and cough. There's some kind of interstitial lung disease. The HRCT may have been obtained or not, but typically along the way, they will get serologies to rule out an underlying connective tissue disease. The HRCT is really the central diagnostic modality that determines where to go next. Sometimes one can stop at the HRCT and say, this is a UIP pattern, and I believe this patient has IPF, or this is a possible UIP pattern, but because the patient is 75 years old, a former smoker, and there's nothing else going on, the likelihood is very high to make a diagnosis of IPF, and therefore I'll stop right there. But as pulmonologists, when we see these patients, we have to take into account the global care and global management, and it's not just making a diagnosis, but coming up with a management plan thereafter. So management might include one of the antifibrotic agents, either pirfenidone and nintedanib. If they're young enough, robust enough, without significant comorbidities, they might potentially be candidates for lung transplantation. So workup for lung transplantation can never be too early in IPF because of the unpredictable nature of the disease. What I typically say to patients is, let's hope for the best, but prepare for the worst. Let's hope you stay stable, but let's prepare for the event that you might have a decline at any time by putting a lung transplant evaluation in place as a final safety net. Pulmonary rehab is very important for all patients as their disease progresses. Invariably, most of them will require oxygen therapy at some point. Palliative care also becomes important for symptom control, as does hospice as patients head towards the later stages of their disease. We should also be on the lookout for comorbidities which might affect their quality of life as well as potentially impact on their mortality. And then even though we have 2 drugs available to treat IPF now, we still got a ways to go, and patients should be offered the opportunity to be evaluated for enrollment in clinical trials.